Thank you very much, Mary, and thank you very much for inviting me and giving me this opportunity to present my my research findings. It's a great privilege to do so. And I would like to talk about cross-patient mobility and especially the reimbursement rules. And well, it's known from the case law of the court, like Gronden, Smits-Peerbooms, Watts, and all those famous cases, that EU law has a considerable impact on the national healthcare system and also the reimbursement of the cost of this system. A couple of years ago, 9 years ago, the Directive on Patient Mobility has been adopted, which is now subject to a review process. And in my view, this patient directive has greatly contributed to cross-border patient mobility, but also has complicated the European rules dealing with this. And the reason for this is that it applies together with the regulation on social security coordination to cross-border healthcare, and that makes it very confusing. In order to show how this works out in practice, I would like to focus on the situation in the Netherlands, how we dealt with the rules in the Netherlands. I would like to use the Netherlands as a kind of case study in order to show that somehow the European rules should be checked. That's my point. So what I would like to do as a case study, the following question: are the current reimbursement rules for Dutch healthcare in line with the Directive on Patient Mobility and with the Social Security Coordination Regulation? And it is a case study. It's a bit. I only will discuss one provision of the Dutch healthcare system, but this provision is capable of causing a lot of troubles. It even has led 6 years ago to a political crisis, which almost meant which always implied the end of the Dutch cabinet, the Dutch government. But what I would like to do is to discuss to start with the main lines of the directive. What does the directive say about cross-border healthcare? Also pay some attention to the case law preceding the directive. Then I would like to move on to the regulation and focus on what the regulation says about cross-border healthcare. And then I would like to review the Dutch system in the light of those two pieces of EU legislation. And I will focus on the main lines and try not to be too technical and too boring. Those are complex rules, so I'm a little bit overshooting if I think I could entertain you with this talk, but I would like to present in a way which is not too bad. Yeah, I think the rules are complex. I would like to ask you to embrace yourself for the talk I have to give, and I hope it somehow makes sense. At the end of the day, it's about health and money, which are important matters of life, of course. Let's start with the directive. What was the case law preceding the directive? The road to the directive was paved by the case law of the Court of Justice. It is famous case law. Just summing up, I think you are all aware of what the court has said.
Okay. Sorry to interrupt, Johan. I can only see the first slide.
Oh,
I'm not sure where you're up to.
And now?
No.
Only the first slide. I have the second slide, the road to the directive.
Okay. No, I can just see the first slide at the moment.
Probably I should stop the presentation and use that could be helpful. And now do you see the?
Yep, that's moving through now. Could you put it on the sort of slideshow setting, the afspelen vanaf het begin?
Yeah, I've done that way. Yeah, but I have done that, and then you won't see only the first slide.
Oh, okay.
Is it doable for you or?
Yeah. No, this is fine.
Yeah.
Yep. Sorry.
Okay, I will continue. This is the central question. The current rules of the Dutch healthcare system, are they in line with the regulation and the directive? And I would like to start with looking at the directive. And the road to the patient directive is paved by the case law, which always focus on the prior authorization scheme for receiving reimbursement costs of treatment received abroad. This prior authorization scheme was regarded as a restriction of free movement, but could be justifiable and for reasons for exceptions closely related to health. But of course, it was important that the proportionality principle was met. And then here the court made this very important distinction between care that must be planned, mostly hospital care, and care that must not be planned or not necessary to plan, which is non-hospital care. So that's the way the court dealt with it. Of course, the directive aims at codifying this case law, and I would say the most important, the key provisions of this directive when it comes to reimbursement are Article 7 and Article 8 of the directive. Article 7 is very generous. When I read it for the first time, I was kind of surprised because the article simply says that patients are entitled to reimbursement of the cost of all treatments covered by the directive, of course, and by the national healthcare systems, all treatments received abroad. And the tariffs that should apply are the tariffs of the state of affiliation. So let's say the state where a particular person is insured or where the national healthcare system operates. And it should not exceed the actual cost. So that's a very generous point of departure, but there are some exceptions available. Those exceptions are laid down in Article 8. And I would like to focus on the most important exception, which is the exception which has to do with planning. So prior authorization schemes may be in place for a limited number of reasons, and the most important one is that the healthcare services need to be planned. And again, I would say this is mostly related to hospital care. Article 8 also says, and this is, I would say, consistent case law, that authorization must be given if a patient cannot be treated without undue delay. So what's important to note, I would say, that the directive is based on a, the directive is based on a distinction between care that must be planned and care that does not need to be planned. So this argument of planning is important. And one would have accepted that, well, now we have covered all reimbursement rules, but that's not true because we also have, as we just discussed at the beginning, the Social Security Coordination Regulation. And well, I'm a normal European lawyer. Normally, I'm engaged in matters of internal market law, competition law, and I'm very afraid of the Social Security regulation because it's so complicated. But I will give it a try to master it and to relate it to the directive. What does the Social Security Coordination Regulation say? Of course, it's aimed at free movement of persons, facilitating people like workers which live in one member state and work in other member states to get their entitlements under various systems of Social Security. And also the Social Coordination Regulation applies to cross-border healthcare. When it comes to cross-border healthcare, I would say the point of departure is care that is anticipated and care that's not anticipated. Those are the terms I use myself, but I will explain what I mean by it, and actually it's taken from the setup of the regulation. Non-anticipated care means that somebody is traveling abroad, so we cannot hardly imagine it anymore, but before the crisis, before the corona crisis, sometimes abroad, for business purposes or for because we were tourists, for leisure purposes, we were abroad, and maybe you could fall ill, and then you need to be treated, and also the cost of the treatment had to be reimbursed. And the regulation contains a mechanism guaranteeing this. So you are, for instance, you live in the Netherlands, and you are in France on holiday, you fall ill, and then the regulation guarantees that you will be treated in a French hospital, that indeed the costs are covered, and that the tariffs of the country of treatment, in this case France, are applicable. But people could also, of course, travel to another country in order to get treated. And I would like to refer to that as care that is anticipated care by the patient. And in that case, you need prior authorization. So the prior authorization is indeed a key mechanism for getting your money back for treatment you have received in another member state. And it's a little bit, of course, confusing given the setup of the directive. So you need prior authorization. Authorization it's up to the discretion of the public authorities whether you get authorization, so you have room for maneuver there, but authorization must be given, and that's, I would say, totally in line with the directive, so that the regulation has in common with the directive. Authorization must be given if you cannot be treated without individual aid in your own country. But given the role the authorization scheme plays, you could say, well, there is a gap between the directive and the regulation. And how can this gap be bridged? That's the question. One would have expected that indeed the court would have held that the regulation, at least Article 20 of the regulation, which contains the authorization scheme, is somehow in violation of primary EU law, especially the free movement rules. But that's not the way the court dealt with it. And I must say it took me quite some time to understand what the court actually was up to and what kind of solution it supported. But I think the key to the answer how the regulation relates to the directive is in Izan, which in my view is recently confirmed in the case of Facilibas Ministrea. It's a case of one of the Baltic countries. And in Izan, the court said that the regulations, or the authorization scheme of the regulations, the requirement to apply for prior authorization, in fact, is an administrative mechanism. And the aim of this mechanism is to make the life of the patients more easy. So what you have to do if you would like to get your cross-border healthcare costs reimbursed, you apply for prior authorization. And if you're lucky, and if indeed authorization is given, you have a good mechanism which ensures that you will get your money back on the basis of the tariffs of your country of treatment. If not, then you are not lucky, but then you got a second opportunity, which is the directive. Then you could base your claims on the directive and ask, indeed, whether you could get back your money on the basis of the directive. Because this directive indeed aims at harmonizing patient rights and cross-border healthcare matters. Why should a patient rely upon the directive? I can identify two reasons. The first reason is that tariffs are higher in the member state of affiliation where the patient lives than in the member state of treatment. In Van Braak, I must admit, this gap was indeed breached by the court by saying that indeed if there's a difference, then this difference must be covered by the member state of affiliation. But anyway, it's more easy to go directly to the directive if indeed the tariffs in your own country are higher than the tariffs in the country where you would like to get your treatment. And then more importantly, I would say, is the second circumstance, and that's is related to the prior authorization scheme. So if prior authorization is not given, or you fear that prior authorization will not given, it's way more better to rely upon the directive, because under the directive you have the opportunity to challenge the authorization scheme and even to argue that the authorization scheme is not valid because it's not in line with the directive. Whether this holds true, of course, depends on the question whether the care you would like to receive must be planned or does not need to be planned. Okay, that's the relationship between the regulation and directive. And how does this play out in the national legal order? And I would like to focus on on the Dutch situation, on the reimbursement rules in the Netherlands. I would like to highlight some of the basic features of our system in the Netherlands. The purchasing market is very important in the Netherlands because we have a market-based system. So the private health insurance companies are supposed to contract care on those markets and indeed to negotiate with healthcare providers and to get nice treatment at affordable prices. So the underpinning principle is that those market-driven systems will lead to high quality and also to some kind of cost containment. Whether that's true, that's difficult to predict. Probably you can may question that, but that's one of the principles underpinning our system. So it means that a very important distinction exists between care that is contracted and care that's not contracted. You can imagine if the purchasing market should really take off, then it's very important that the patients will go to a provider contracted by his or her insurance company. And what will happen if such a patient will go to a provider not contracted by the insurance company? And here I think it's very important that Article 13 comes into play. Article 13 of our insurance bill that says that a person insured is still entitled to a proportion of the costs when he goes to a provider not contracted by his insurance company. And we have a debate about, let's say, the exact level of those costs, but it's apparent from the case law, if you study all the cases we have and also some information put out by the insurance companies on internet, that you could argue that you are entitled to 85% of the costs, which you would normally have received if you would have gone to a provider which was contracted by your insurance company. So you still got some money back, but it's not the entire level that will be reimbursed, will be covered. How does this sit with European law? I think the most important thing I would like to point out is that we have problems with Article 7 of the Directive, and especially Article 7.4, which says that you are entitled to reimbursement of the cost at the level you would have received if you were treated by a provider in your own country, by the provider of the country or the member state of affiliation. And the point is, that's apparent from cases like Smits-Peerbooms and also Watts, that the court is of the opinion that normally contracts are concluded by insurance companies with domestic healthcare providers, and only in exceptional circumstances with healthcare providers operating in other member states. But you could argue that if that Article 30 to a certain extent results into indirect discrimination, because let's say in the majority of the cases, if you go to a provider based in other member state, you only will get reimbursed 85% of your costs, because you may assume that this healthcare provider does not have a contract with a Dutch insurance company. So I'm afraid that Article 7, and more particularly Article 7.4, is infringed because it does not allow for indirect discrimination, which is also clear from the drafting and references made in other sections of Article 7. And then, of course, you have to check whether an exception is available. And then we have to check Article 8 of the directive. And the problem with Article 8 is that the exception is based on an authorization scheme. And that's not a surprise, because Article 8 is a codification of the case law of the court. And the case law of the court has indeed focused on, let's say, state-driven systems, which also was the Dutch system a couple of years ago when Smits-Peerbooms was handed down. The court has focused on state-driven systems, and in state-centered systems, of course, authorization schemes are very important. Market-driven systems like the Netherlands, it's a little bit of a problem. So I think you cannot rely on Article 8 because the authorization scheme is absent in our system. At least it's absent in the sense that it's not incorporated in the Dutch insurance bill. But the other thing is, and I would like to point out that according to Article 20 of the regulation, at least, we should have some kind of authorization scheme. So if Dutch private health insurance companies are confronted with a application made on the regulation, they have indeed to apply an authorization scheme, because Article 20 requires so, and they indeed are required to give authorization if the patient concerned cannot be treated without undue delay in the Netherlands. So that's a kind of second, let's say, bottleneck, that although authorization schemes formally do not play an important role, Dutch insurance companies are required to apply those schemes if a patient indeed sends in an application under the regulation. So we have a lot of problems and tensions, and the question is how to solve this. Well, when it comes to the Dutch legislator, I think the only way out will be to incorporate somehow an authorization scheme in the Dutch system, and to apply it to care that's subject to planning. It's at least that you think it should be controlled somehow. The outflux of patients should be controlled somehow. Then I think when it comes to care that needs planning, an authorization scheme should be introduced. And I think the only thing what the Dutch legislator can do is accepting this authorization scheme, although it's a little bit alien to the setup of our market-driven system. But more importantly, I would say, is that the union legislator should somehow change its views and its vision on cross-border healthcare. And when doing so, I think two important ingredients, two important notions should be taken into account. And that's the first thing is, of course, the rights of patients. And the second one are the national healthcare competences, the respect for the national healthcare competences. But this is kind of my tentative proposal. I don't think it will be followed up on, because one thing I've not included, and that's the power of politics, of course. And that indeed member states would like to control their own national systems rather than giving some competences to the EU. But from a legal point of view, if you have to draft a system which I would say makes sense and is somehow coherent, I think it's very important to include the reimbursement rules in one particular EU measure. So to incorporate it, to integrate it in one particular EU measure. And then you could make a distinction between anticipated and non-anticipated costs of cross-border healthcare, so anticipated and non-anticipated costs of cross-border healthcare. Non-anticipated costs of cross-border healthcare could be dealt with in the same way as the regulation does right now. So we have an efficient mechanism which guarantees that you will be treated when falling ill in other member states in accordance with the tariffs of the member state of treatment. I think more important is to take a look at anticipated care, so patients which deliberately travel to other member states to get treated there. And here probably you could subdivide it into care that must be planned and care that does not need to be planned. For care that must be planned, you introduce an authorization scheme, which gives the member states the possibility to control and to contain the cost concerns. And for the non-anticipated care, it's not necessary to have in place an authorization scheme. And you could say member states are precluded from having such a scheme in place when it comes to non-planned care. And I would say the level of reimbursement of the costs could indeed be determined in line with the tariffs of the member state of affiliation, because I would say in that case you will respect the healthcare competence of member states and give the member states opportunity to contain the costs incurred with healthcare. So that would be probably a nice move, something you could consider. And the last thing, if I may, I'm a little bit exceeding the time limits, but the last thing I would like to point out, and that's I would say a perspective from the Netherlands, probably it would be nice to have this set of rules in a regulation, so that the EU should lay down the reimbursement rules in a regulation. The point with the directive is that if the directive is not implement in the correct way, you are confronted with the question whether the directive has direct effect and also whether directive has horizontal effect. So the point is a directive which is not implemented or not correctly implemented cannot be applied vis-à-vis a private party, including a private enterprise. And since we in the Netherlands have a market-driven system, private insurance companies are the managing bodies, so they play a key role. And now in the Netherlands, we are confronted with the question, because Article 13 of the Dutch Health Insurance Act is not in line with the directive. We are confronted with the question whether the patients can rely actually upon Article 7 of the directive, because their disputes concern a horizontal relation with the insurance company. So that's also a very difficult question, which is hard to solve. So these were kind of my my reflections on the directive and the regulation, and also my plea for integrating them in one EU measure. So thank you for your attention. I'm looking forward to your questions.
Okay, thank you very much, Johan. I'll just stop the recording.